Assalamu alaikum. Now I would like to discuss about a very high yield topic of respiratory system, that is ARDS. What does ARDS stands for? ARDS stands for Acute Respiratory Distress Syndrome. In acute respiratory distress syndrome, we have to think about the past. What does the past means? Pancreatitis, aspiration, sepsis, pancreatitis, aspiration, sepsis, trauma and transfusion, trauma and transfusion. So the risk factor you have to think about the past. What are the pathophysiology here? In here there is lung injury. In here there is inflammation and fluid leakage into the alveoli. Suppose it is an alveolar sac, if there is fluid leakage into the alveoli, if there is fluid leakage into the alveoli, it may cause ARDS. For ARDS, you have to remember again the fourth thing, ARDS. That means symptoms of respiratory failure, symptoms of respiratory failure within 1 week of insult. First of all, abnormal chest x-ray, abnormal chest x-ray, abnormal chest x-ray, that means bilateral lung opacity on imaging. Then the respiratory failure within 1 week of clinical insult. Third one is decreased PaO2 FiO2, that means PaO2 FiO2 ratio is less than 300, and symptoms of pulmonary edema not explained by heart failure or any sort of volume overload. So for diagnosis of ARDS, that means abnormal chest. For diagnosis of ARDS, abnormal chest x-ray, that means bilateral lung opacity on imaging, respiratory failure within 1 week of clinical insult, decreased PO2 FiO2 ratio, PO2 by FiO2 ratio, PO2 by FiO2 ratio less or equal 300, and symptoms of heart failure or symptoms of pulmonary edema not explained by heart failure or volume overload. Management is mechanical ventilation. In here, management is mechanical ventilation, low tidal volume, high peak. There is low tidal volume, there is high peak, high FiO2, and permissive hypercapnia. That is low tidal volume, high peak, high FiO2, and permissive hypercapnia. So again, fourth thing, tidal volume should be low. We calculate the tidal volume. Usually before giving a mechanical ventilation, we calculate the tidal volume. Actually 6 to 8 ml per kg of tidal volume is usually given. High peak, usually we give 5 centimeter of water peak, but in this case we should go for 10. So low tidal volume, that means 6 ml per kg of tidal volume, high PEEP, high FiO2, and permissive hypercapnia. Suppose a patient with 38-year-old man comes to you. 38-year-old man comes to you with comes to the emergency department with high-grade fever, chills, productive cough, shortness of breath. He has 2 hospital admission for alcohol withdrawal seizure in the past but continues to drink. The patient has no other problem. Temperature is 39.7, blood pressure is 100 by 70, pulse is 110, permanent skin and mucous membrane are dry. Physical examination reveals crackles and bronchial breath sound in the right lower lung. Chest X-ray reveals right lower lobe consolidation, and the patient prescribed an intravenous NRV mask. The repeat X-ray done. The patient is intubated immediately. Which of the following is the most likely to be present in this patient just prior to intubation? The most commonly AR the most common the patients most commonly has the patient most commonly has ARDS due to infectious pneumonia and sepsis. In this patient, what I have told you, the history of what I've told you, that high grade fever, productive cough, fever, cough, and sputum, that means pneumonia. And he has 2 hospital admission for alcohol withdrawal seizure in the past year. So pneumonia, that means infection causing ARDS. The lung injury causes release of the protein inflammatory cytokine neutrophils into the alveolar space, leading to leakage of the fibroproteinaceous fluid into the air space, and alveolar collapse and loss of surfactants. These causes impaired gas exchange, leading to hypoxemia due to profound VQ mismatch from intrapulmonary shunt, decreased lung compliance, and increased pulmonary arterial pressure due to hypoxic vasoconstriction and destruction of the lung parenchyma. During treatment with mechanical ventilation, positive airway pressure causes compression of the pulmonary artery and further contributes to increased pulmonary artery pressure. So in ARDS, the result would be impaired gas exchange. Why there is impaired gas exchange? These leakage of fibroproteinous fluid enters into the alveolar space and thus leading to hypoxemia, and impaired gas exchange leading to hypoxemia due to profound VQ mismatch from interpulmonary shunting. There is decreased lung compliance, that means there is decreased ability to expand the lung due to loss of surfactant. Why there is loss of surfactant? Release of proteins, inflammatory cytokines, and leading to leakage of the proteinaceous fluid, and increased pulmonary arterial pressure hypoxic vasoconstriction due to hypoxic vasoconstriction and destruction of the lung parenchyma during treatment with mechanical ventilation. Positive airway pressure causes compression of the pulmonary artery and further contributes to increased pulmonary arterial pressure. So in ARDS, it involves acute pulmonary edema and diagnosed by hypoxemia and bilateral alveolar infiltrate that are not explained by cardiac dysfunction. Okay, in here I have already told you about this lung injury causes release of the proteins. That means due to pneumonia, it may release the proteinaceous fluid in the alveolar space. So gas exchange is impaired due to VQ ventilation perfusion mismatch. There is decreased lung compliance and pulmonary arterial pressure is increased, leading to pulmonary hypertension due to hypoxic vasoconstriction, destruction of the parenchyma, compression of the vascular. Okay, ARDS following trauma do not manifest until 24 to 48 hours following a traumatic event. This is a very high yield thought that trauma do not ARDS following trauma do not manifest until 24 to 48 hours following event. ARDS usually takes place in 6 to 72 hours to evolve after the inciting event and causes more diffuse bilateral infiltrate on X-ray. In general, oxygenation may be improved. In general, oxygenation may be improved by increasing either the fraction of the inspired oxygen or positive end expiratory pressure provided by mechanical ventilation. PEEP. PEEP prevents alveolar collapse. It prevents alveolar collapse due to respiratory cycle and may also reopen some alveoli that may have already collapsed. So PEEP actually prevents alveolar collapse. PEEP prevents collapse. PEEP prevents collapse. PEEP prevents collapse and also reducing and open some alveoli that have been already collapsed and reducing shunting. Therefore, in ARDS patients, increasing PEEP is the best next step, as it would not improve oxygenation by directly counteract one of the mechanism by ARDS causes hypoxemia. High PEEP approaches may improve mortality in patients with severe ARDS. So we know that PEEP prevents collapse. PEEP prevents oh, most patients with ARDS require mechanical ventilation. Most patients with ARDS require mechanical ventilation with the following goals: avoiding complication of the mechanical ventilation by using lung protective strategies. That means lung protective strategies, low tidal volume ventilation, LTTV 6 ml per kg of the ideal body weight results in lower pulmonary pressure, decreasing the likelihood of the over-distending alveoli. In addition, it improves mortality in patients with ARDS, providing adequate oxygenation Increasing the FiO2. Increasing the FiO2, prolonged FiO2 level more than zero point 0.6 are associated with oxygen toxicity and increasing PEEP. Given the severe hypoxemia seen in ARDS, PEEP level up to 15 to 20 centimeter of water may be necessary to maintain oxygenation. So low tidal volume ventilation 6 ml per kg, high PEEP 15 to 20 centimeter of water. The goal of the arterial pressure, the PaO2, is 55 to 80 millimeter of water, or peripheral SpO2 is 88 to 95%, preventing SpO2 less than 88%. So low tidal volume 6 ml per kg, high P 15 to 20 centimeter of water. Low tidal volume, high P. Low tidal volume ventilation is a strategy with an increased risk of hypercapnia and respiratory acidosis. With an increased risk of hypercapnia and respiratory acidosis. However, the permissive hypercapnia is well tolerated and not associated with increased mortality of the ARDS. The PaO2 is an important measure of oxygenation and is influenced mainly by FiO2 and PEEP. The arterial partial pressure of carbon dioxide PaCO2, a measure of pulmonary infiltrate, is affected mainly by the respiratory rate and the tidal volume. This is a very important box, ARDS. If you diagnose a case of ARDS, then we try to ventilate the patient. Mechanical ventilation, intubation is a must. In here, oxygenation, FiO2 should be, PEEP would be 5 centimeter. Initial ventilator setting, PEEP is 5, FiO2 is, tidal volume is 6 ml per kg of the body weight, and respiratory rate 14 to 80. So FiO2 100, PEEP 5, tidal volume is 6 ml per kg, and respiratory rate is 14 to 80 per minute. If adequate oxygenation and adequate oxygenation, that means PaO2 is more than 90. If PaO2 is more than 90, that means hyperoxia. If I would, FiO2 should be decreased. If PaO2 is more than 90, our target is 55 to 80. If FiO2 is, if PiO2 is more than 90, then FiO2 should be decreased. If PaO2, if arterial oxygen, that means hypoxia, is less than 60, then PEEP should be increased. Then adjust ventilation. How will you do adjust ventilation? We'll do two things. We will see two things. pH, if it is less than 7.5. If acidotic, then you should increase the respiratory rate and increase the tidal volume. It's a last resort. If alkalotic, you have to decrease tidal volume first, then respiratory rate, and increase sedation is the last resort. Ensure lung protective ventilation, avoid alveolar over distension. This word is very high. I'll avoid alveolar over distension. Evaluate lung compliance, measure P flat with inspirator hold and goal. P flat uh, is less than 30 centimeter of water, decrease tidal volume and adjust P. In ARDS, management and prognosis, mechanical ventilation, lung protection, limiting alveolar overdistension, tidal volume less than 6 ml per kg, P flat is less than 30. So 630. Ventilation tolerable, permissive hypercapnia, PaCO2 is more PaCO2 is more, pH is less to avoid excessive VT, and oxygenation set lowest feasible FiO2 to avoid oxygen toxicity. Supportive treat the underlying etiology, source control, sepsis, preventing iatrogenic harm, negative fluid balance, timely extubation and minimize sedation, and finally corticosteroid. Select patient with moderate to severe in early ARDS. Mortality rate 40% in hospital, death most due to organ failure, morbidity 50% in chronic, cognitive impairment, physical disability 25%, chronic pulmonary dysfunction, restriction and decrease DLCO. Patient with ARDS have an positive fluid balance, volume resuscitation for sepsis, blood transfusion, trauma during hospitalization, a conservative fluid strategy aimed at achieving a neutral or negative fluid balance, accelerate recovery from ARDS with trend toward improved survival rate. The goal is to accomplish by minimizing intake, avoiding unnecessary fluid bolus, concentrating IV drip, prompting removable diuretics, renal replacement therapy. Patient with refractory hypertension, septic shock should be assessed with fluid responsive or other vasopressin may be required to support hemodynamics to permit volume removal. And that's all about ARDS. Hope you enjoy.